cancer, global statistics. The stomach cancer is the fifth most commonest cancer in the world, and it's the fourth most commonest cancer causing death in the world. But if you look at the world distribution of the stomach cancer, you see the sheer contrast. So there's a lot of area in the dark blue, which is the area where you will see a lot of stomach cancer. The stomach cancer is primarily located into the Asian countries and the part of the Asian part of the Europe, the eastern part of the Europe, and some part of the Latin America. So the Asia make almost 75% of the stomach cancer, where the Europe makes around 12%. So Asia and Europe are making around 90% of the stomach cancer, where the North America is only 2.7%. In India, the stomach cancer is somewhere around at third and fourth place. So the carcinoma of stomach, the two things are very important for the histology point of view. There are two main subtypes of carcinoma of stomach. One is the diffuse type, another thing is the intestinal type. These two things are very important because if you see the intestinal type of adenocarcinoma of stomach, it will show you the good amount of FDG uptake, where the diffuse type of gastric adenocarcinoma will show a less amount of FDG uptake. So these 2 points has to be clear. This is called the Lawrence classification, which was given in 1965, and this classification still holds true. The diffuse type of gastric adenocarcinoma, now it has been renamed as poorly cohesive SRC. So probably when you see the histopathology, it will be written as a poorly cohesive signet ring cell carcinoma. So carcinoma stomach staging, we follow the AJCC classification, and when we do a staging for a luminal organ, we always talk about the depth of invasion. So that is the T stage, and the N stage is the extent of nodal involvement, and is the distant metastasis. So for the T stage, if you look for the histology, yes, this is mucosa, submucosa, then there is a muscularis externa and subserosa and the serosa. But on the CT scan, it's actually very difficult to identify all these layers. So if you see at the CT scan on the right side, this part of the distal body of the stomach, you will see only a single layer. And this proximal part of the body, you can see there is a mucosal fold. So this is the mucosa, and then there is some hypodensity. So this is the submucosa. And then there is a single layer, which is actually a combination of the muscularis externa, subserosa, and the serosa. So on a CT scan, it's actually very difficult to identify whether the lesion is T1, T2. But to some extent, we can say that when there is involvement of full thickness, it's probably a T3 lesion. When you can see some perigastric strandings, it's probably a T4A lesion. And when it is involving the adjacent organs, so it's probably a T4B lesion. So this much information definitely we can say. Otherwise, to differentiate between a T1, T2 is very difficult on a CT scan. So probably that is the reason if you see the clinical TNM staging for the carcinoma stomach, they have grouped the T1 and T2 together. So the stage 1 where T1 and T2 is together, and if you have a nodal positivity, then only the stage will be higher. Similarly with the T3 and T4A, it has been grouped together. And when you have a nodal station positive, it will be a higher stage. And T4A is easy to identify, T4B is easy to identify. For the carcinoma stomach, for the end staging, we follow the Japanese gastric cancer resolution nodal station, and it has been adopted by the AJCC as well. So there are 6 nodal stations which are called the perigastric lymph node. So this is one is called the right paracardic lymph node. This is station 2, which is called left paracardic lymph node. Then the lymph node which is along the lesser curvature of the stomach is, then there is a lymph node which is along the greater curvature of the stomach. And there is a lymph node which is above the pyloric canal and below to the pyloric canal. So this is station 5 and this is station 6. So these are the perigastric lymph nodes. Then there are certain lymph nodes which are called extragastric lymph nodes. These are again the lymph nodes which are taken to be a regional lymph nodes, like the lymph node which are along the major vessels which is supplying to the stomach, which are the part of the celiac trunk. So like we have the station 7, which is left gastric artery trunk, and then station 8, which is common hepatic artery, and the celiac artery, and the splenic artery, and the hepatoduodenal ligament. So up to this station, it is a regional lymph node, and the surgeon can still operate. So if you report any lymph node beyond to station 12, it will become a metastatic lymph node, and surgeon tends to defer the surgery or a curative intervention in these patients. As per the Japanese system, they take superior mesenteric vein as a regional lymph node, but as per the AJCC, they take it as a metastatic lymph node. Then there is a lymph node which is along to the diaphragm. There are lymph node which is below to the diaphragm and slightly above the diaphragm. So if you have a stomach cancer which is involving the esophagus, then these lymph nodes become a regional lymph node. you have a stomach cancer which is not involving the esophagus, then this will become a metastatic lymph node. So these points you have to be clear in your mind when you are writing a report, whether you are writing a metastatic disease status or whether you are writing a regional or local regional disease status. Again, for the pathologists, we take the number of lymph node positivity, but for the clinical case study, we take the whether a lymph node is positive or not. Even if a single lymph node is positive, you have to write an N1 status. Then there are certain CT characteristic has been defined in the definition, like short axis diameter 6 to 8 mm for the perigastric lymph node, round shade, central necrosis, loss of fatty adenum heterogeneous or high enhancement. CT sensitivity is somewhere around 62% to 91%, but truly speaking, there are local consensus are lacking, and because we have to follow the CIS 1.1 criteria for the responses, so we take 1 centimeter short axis diameter to say is a pathological lymph node or not a pathological lymph node. For the carcinoma stomach, I'm feeling again it's one of the tumor which has a lymphatic dissemination, as I have discussed earlier. Then there is some peritoneal metastasis, which is basically a metastasis along the perigastric lymph nodes, perigastric ligaments. Then transperitoneal staging, which is the metastasis to the peritoneal cavities. Then there is the hematogenous dissemination. So hematogenous dissemination is more common with the intestinal type of gastric adenocarcinoma, where the SRP type or poorly cohesive type will have a more peritoneal metastasis. So whenever you are reporting, you have to clear in your mind. And again, as a nuclear medicine physician, I think to understand and to know the guidelines is very important. So for the NCCN guidelines, the role of PET scan in stomach cancer, they have said the PET scan can be used for evaluation if there is a no M1 disease. And it can be used when it is clinically indicated, or you can't do a CT scan like in case of contrast allergy or impaired renal function. And PET CT scan can improve the accuracy rate to 68% versus CT scan, which is 53%. For the ESCO guidelines, the PET CT scan is not routinely recommended in the carcinoma stomach, but it is written that it may improve detection of open metastasis around 10%. But again, it is often negative in diffuse type of gastric cancer. I think we all know that cilia cell carcinoma is one of the falsely negative, or it's not actually a falsely negative, the activity is just like a background. As per the Japanese classification, again, guidelines are same. For the gastric adenocarcinoma, this is endoscopy, CT scan, ultrasound, and the staging laparoscopy. We'll try to discuss two cases. 64-year female with pain abdomen, 1.5 months, constipation 6 months, dyspepsia 2 years, and the loss of appetite. So the ultrasound was done. I think one of the best ultrasound report I have seen. There are two large lymph nodal masses in the perigastric region inferior to porta hepatis. There is a mild, diffuse, irregular thickening of antropulmonary region, which is described as neoplastic etiology. So they have given a lot of information as per the ultrasound information. As per the ultrasound report, the CECT was done, which says mild circumferential enhancing wall thickening in the antropulmonary region, which they reported as T3. There was two enlarged, partly necrotic enhancing lymph node, and we have to write NM status. The lymph node they have reported gastrohepatic, periportal, inferior to pylorus of the stomach, so it is at station 6. Upper G endoscopy shows also proliferative growth, and the biopsy was poorly differentiated adenocarcinoma. So there is the indication of doing a PET CT scan because the surgeon want to rule out the metastasis. So that whenever the PET scan comes to you, you need to know, because the information he has, each stage already he knows, any stage he already knows. You want to know the metastasis. So you have to be careful when you are reporting a PET scan that you should look for metastatic sites, and what are the metastatic sites, you have to be careful. So if you look for the PET CT scan, there is a good amount of FDG, AVPT in the primary side. So this body of the stomach and the antropulmonary region, you can see there is a full thickness involvement of the stomach wall. There is some perigastric stranding, so probably it is a T3A or T4, T3 or T4A region. There is a large necrotic lymph node in the gastrohepatic space, so it is a left gastric artery lymph node, station 7. Then there is the lymph node just anterior to the common hepatic artery, so it's the station 8, and then there is the lymph node just inferior to the pyloric canal, so it's the station 6. So we will write this clinical T3/4A N1 M0. So it's a locally advanced gastric cancer, and we have ruled out the metastasis in this particular case. So what is the next step the surgeon will do? So he will tend to do a diagnostic laparoscopy because he want to make sure there is no peritoneal metastasis. So diagnostic laparoscopy was done and peritoneal lavage was done and it was negative. So the PET scan was actually true negative in this case to rule out peritoneal metastasis. So this is, as an interventional physician, we also need to know what is the next course of action when you report a PET CT scan, what the surgeon will do or what your clinician will do. So this is another case, 50-year female, CS stomach, SRC type. And then you can see there is a full thickness involvement of the stomach wall. There is some perigastric stranding. There is some enlarged lymph node in the gastrohepatic space or the station 7 lymph node. And FDG PET CT scan was also done. Then you can see there is a mild activity into the stomach, and this is what you see normally in the single ring cell carcinoma. And that is the reason we generally, don't encourage to do a PET CT scan in the single ring cell carcinoma because we don't see much amount of activity. And there is a large lymph node which is again not showing much activity. We had the opportunity of doing the FAPI PET scan in this particular case, and you can see the FAPI PET scan, there is a good amount of activity. So when you see this much amount of activity, then you become very confident in reporting the things. So you can see there is a good amount of activity into the stomach. You can see the good amount of activity into the gastrohepatic lymph node. So if you see this sagittal section of a CT scan of the same patient, there is some diffuse thickening into the stomach. There is some, lymph node basically along with the greater curvature of the stomach. So station 4. Then the PET scan was not showing much, obvious things. So if you look at carefully, probably you will be able to see it, but not very obvious things. But if you look at the FAPI PET scan, there is a good amount of, the avidity of the FAPI. And you can see there is a focal activity is coming in the umbilical area. Now, if you see this CT scan, there is already an umbilical nodule which actually the radiologist missed. So this was the nodule which is the umbilical nodule, and probably the patient is already having a metastasis into the peritoneum. And this is what is the Sister Mary Joseph nodule. Once this nodule becomes bigger, the sister is able to see from outside, it becomes a Sister Mary Joseph nodule. So this is how this patient, the FDG PET CT scan was not showing much activity, the FAPI was showing good amount of activity. There was some contamination of, during the FAPI synthesis, there was some contamination of the PSMA, so don't take the message that the FAPI will show you the salivary gland uptake. There was some contamination of the PSMA. Another point which you must see, there is the linear activities coming in the left side of the abdomen. So this is on a cross-section imaging. If you can see, there is some nodularities coming along the parietal peritoneum. So this is how a CT scan will pick up the peritoneal metastasis. Now, once you have this much amount of activity, then the things become more clear. So they also become more clear in their mind that most likely it's a peritoneal metastasis, and this is a metastatic case. So the take-home message, I like to say that 90% of the stomach cancer are in Asia and Europe. So we need to build up more data for the PET CT scan, and now with the FAPI availability, I feel that we should generate more data for the stomach. Pathological subsets are very important to understand the imaging finding because the intestinal type of adenocarcinoma will show you good amount of FDG uptake, where the poorly cohesive will not show you good amount of uptake. We have to start using the CTMA for carcinoma stomach, and we have to look for the peritoneal metastasis very carefully because this is what the indication the physician wants. And the FAPI PET scan may become the new benchmark for the single ring cell carcinoma. So the last point I like to say that things are always there. We have to find the ways to discover them, and probably the FAPI is one of the ways to discover the stomach cancer in a better way. Thank you very much.
Thank you, Dr. Manoj, for the wonderful presentation, which was short, crisp, and comprehensive. Our speaker here with us, so we have a recorded talk from Dr. Vijay Harish. He's a senior consultant and head nuclear medicine at Rajagiri Hospital, Kochi. So, we have his talk with us. We will be starting it.
And there's a good chance that I may not make it there on time. To begin with, oncology PET report essentials that an oncologist wants. The section assigned to me is gender unified. And this I'll primarily be speaking on renal and also touch upon the human tract humans. So to begin with, there have been shown a significant role of FDG PET. The FDG PET positivity and overall survival seem to be related, and also the intensity of FDG uptake. Cancer. FDG PET has been shown to play a significant role in the neural and the metastatic stage of the disease. But despite all of this, it is seen that the guidelines, so this is the NCCN guideline, a lot of guidelines actually recommend an FDG PET CT as a routine investigation in the evaluation of either carcinomas or for that matter other tumors. And also, the American Urology Association categorically states that PET scan has a very important role in the routine evaluation and staging of RCC. And also, this again reflects in our clinical practice also, when we do not routinely get PET CT scan for renal evaluation or renal tract evaluation. So, it is quite evident that a urologist or oncologist does not depend on FDG ability for their clinical decision making. So, what exactly is it that the urologist wants? Are these basic 5 sections? The basic characteristics, the location of the mass, invasiveness, vascular appearance, and others. Going ahead, it is recommended by the Society of Abdominal Radiology that the CT protocol that mass evaluation should have a pre-contrast image, that is the image, the CT image acquired prior to administration of IV contrast, and also a nephrographic phase, which is basically the CT acquired around 90 to 120 seconds following administration of the IV contrast. So typically, in our routine PET CTs, in case we are routinely using IV contrast studies, the CT would happen at around 50 to 60 seconds. That is typically the particular meteorology phase. So moving that to 100 to 120 seconds is not very difficult. So this can pretty much be incorporated